I'm Will Coleman.
My name's Liz Halliday.
My name's Megan Kefferly.
Hi, everyone. Thanks for joining us tonight. My name is Kira Lisa. I am the Regional Director of the Northeast for Hilltop Bio. I also head up a lot of our marketing efforts at the company. And so we're pleased to bring you an educational webinar tonight on joint health, which will feature our intra-articular joint product, Strydaflex. If you have not heard of Hilltop Bio before, we're making a line of cutting-edge regenerative therapy products. So if your horse has a soft tissue injury, a wound, a pesky summer sore, or they receive joint injections routinely, definitely check out Hilltop Bio. You can learn more at our website, hilltopbio.com, or send us a note at info@hilltopbio.com. With us tonight is Dr. Beau Whitaker. Dr. Whitaker hails from Tennessee originally, and he has a degree in animal science from Oklahoma State University, as well as a veterinary degree from Texas A&M. He is also a certified equine rehabilitation practitioner through the University of Tennessee. And he's a partner and busy lameness and sports medicine veterinarian at Brazos Valley Equine down in Salado, Texas. So we're thrilled to have Dr. Whitaker here tonight to talk about joint health and a little bit about Strydaflex, Hilltop Bio's joint product. When Dr. Whitaker isn't busy seeing patients on a day-to-day basis, he spends time with his family, especially outdoors, and he's actually a very talented artist and sculptor. So I'm sure Dr. Whitaker will be having an art-only website for himself. But in the meantime, he stays busy treating horses. So I will turn it over to you, Dr. Whitaker. Thank you for being here tonight.
Great. Thank you, Kara. All right. All right. So we're here to talk about joints. If you showed up here thinking that it was something other than horse joints, then you're on the wrong webinar, and I suggest you find the one you meant to be on. But here today, we're talking about joints and horses. And specifically, we're going to go over a little bit of the anatomy, kind of understand why sometimes these joints get painful. And then we'll talk about some different therapies that are available, mostly focusing on the Hilltop Bio product Strydaflex, but we'll also go over the multiple products that are out there and kind of the thinking that I go through when I'm trying to decide what I want to use. As she mentioned, I am at Brazos Valley Equine Hospital, about 1 hour north of Austin, Texas. I am on the advisory board for Hilltop Bio as well, just as a disclaimer. Okay. All right. So let's just do a little basic joint anatomy. So just we understand what's going on inside that joint. So joint is basically just where two bones come together. And so you have this area that has got to hold them together and also has several functions. But basically, you have a bone on each end. In the middle, you have the synovial space, which contains fluid. That fluid is produced by the synovial membrane, which you can see there in the picture. And then outside of that membrane, we have a joint capsule. So that's just basically, those are just the basic components. We'll go over a few other things as well. But when you think about basic joint anatomy, it's basically two bones with cartilage on the end of each bone, as you can see in the picture, the membrane and then the capsule. So what does a joint do? Well, in the horse's case, the joint has to carry the horse. It has to be able to weight load. So if you think you have this animal that weighs 1,000 pounds, when it's standing, it's a lot of weight. But when that horse is running or jumping, it's a whole lot of weight. And so those joints have to be able to take that concussion. They have to be able to shock absorb, and they have to stay stable as well, because you don't want those joints shearing or those bones shearing as those horses move, because obviously that's going to create issues. Joints don't actually move. They are moved by muscles. And so when we think about that joint articulating, those are muscles that are moving that joint. So that's a big component of this whole picture, is thinking about the components that make that joint move. So here's a little bit more intricate diagram of a joint. So of course, as before, we have our bones, we have our cartilage, we have our membrane, we have our capsule. But also joints will have ligaments around them. So a ligament is a soft tissue structure that connects bone to bone. And so you're probably familiar with hearing the word ACL, the word MCL. MCL stands for medial collateral ligament. So those are all stabilizing ligaments of a joint. So they keep those joints from moving side to side or front to back. So the collaterals are typically on the sides, and then they will have other ligaments on the front and back depending on the joint. And then in most all joints, we have extensor muscles, which are muscles in the front of the joint. So those muscles, usually start out at muscles at the upper part of the limb, and then as they come down the limb, they turn into tendons, and those tendons attach to bone. And so when those muscles contract, it pulls that tendon, and the tendon pulls the bone. So if we have an extensor muscle, that's the muscle in the front. And so if we think about like an ankle joint, as that extensor contracts or pulls, it pulls that bone forward. In order for that to come forward, the flexor muscles, which are on the back side, have to relax at the same time. So we have this intricate play of the muscles on one side contracting at the same time that the muscles on the other side relax. And so the same thing for a limb to flex or go back. The flexor muscles will contract and the extensor muscles have to relax. There's also a structure here called a bursa, which that's a structure, a synovial structure, kind of like it produces fluid like what's in a joint. It just kind of forms as a shock absorber and buffer between a joint and a tendon. It's not in every joint, but a lot of joints in the body will have some type of a bursa that just keeps that tendon from rubbing up against that joint. And those bursas are something else actually that we do treat, like we do with joints with different injections if they get inflamed, with the similar type of injections we use on joints actually. And these tendons also form a stabilizing on a lot of joints. The tendons will also help stabilize that joint as well. So these laws aren't important, but I just wanted to bring them up so we kind of have a concept of how the body works in concert when we have in normal, but there's also in cases where we have arthritis or pain in a joint. So Hilton's law basically just talks about where if we have nerve pain in a joint, it causes a reflex spasm of the muscles. So the muscles that are going to be around that joint, or the tendons that innervate the muscle, or the tendons that are connected to the muscles around that joint, will position that joint in the greatest comfort. So if you notice your horse normally stands pretty square, and then all of a sudden that horse starts to cock an ankle forward or relax a hock or something like that, sometimes that's just positional and they're just resting it that way. But if it's a repetitive thing, you might start thinking, that I wonder if that joint hurts, and the horse is just not even thinking about it, but the body automatically positions it in the position that it's going to be the most comfortable. There's a similar type arc here that when we look at joint pain, that's a feedback loop. So you don't have to think about it; the body just automatically does it. Where we have the same nerves again that innervate the joint and the skin, also innervate the tendons and muscles and everything around it, so that when we have joint pain or instability, those muscles will automatically start to tighten some around that joint to try to help stabilize it. Typically, with more stability, we have less pain in most cases. So why do joints get painful? Well, there's lots of reasons, and this list doesn't even come close to encompassing all the reasons, but I at least wanted to point out some of the main ones that we encounter. So first of all, we can have genetic or developmental disorders to joints. Again, there's many of these. I just listed two here. One is osteochondrosis dissecans, which is a developmental disorder that we see typically in our young horses when we first notice it. At 1 to 2 years of age, these OCDs form. Oftentimes, they will resolve on their own as they get older, and sometimes they don't. Sometimes we have to intervene surgically or with an injection. So these deal with the formation of the cartilage and the bone underneath the cartilage doesn't form correctly during early development. We'll also see sometimes what we call juvenile OA or osteoarthritis. So in this condition, most commonly we'll see you might look at a horse that's 2 years old and the hocks are already fusing. So that's a case of juvenile osteoarthritis. Then we look at mechanical stress. So this is probably the largest area that we end up treating, is just stress on those joints. That can be stress from overuse. So that may be just the horse is being worked too hard, but sometimes it's overuse of a certain area based on that horse's discipline. And so, you may have jumpers where they're more prone to having some fetlock issues versus maybe a dressage horse who's more prone to having sometimes stifle issues because they've got so much weight on their back end. So we can think about overuse in that way. Also, we can have horses that sometimes have hypermobility issues. You'll see those really elastic horses that can really move, which actually makes them sometimes more desirable from a movement standpoint because it looks nicer. But all those horses are hypermobile, which that can lead to suspensory problems, to joint issues as well. And then also, we'll see a lot of horses that get mechanical stress due to alignment or malalignment. So one example of this would be your pigeon-toed horse. So where they're at their fetlock or below their fetlock, they kind of turn in a little bit. And so what this does is it overloads the inside part of that joint because the bones aren't lined up. And so whenever that foot hits the ground, the force is transferred not evenly across the joint. So over time, I'll see a lot of pigeon-toed horses that develop osteoarthritis in their fetlock joints because of this alignment issue. We also see injury or trauma. Now, some of these will overlap. Like some horses you see, they don't just have one thing. They may have, injury or trauma that's related to overuse or malalignment. But injury, we typically think about something that's more acute. So the horse was sound yesterday. Today it's lame. And so injury obviously can be lots of things. It can be bone trauma. It can be cartilage trauma. It can be injury to the soft tissue around a joint. But all those things can contribute to this causing joint inflammation and pain, which can then lead to osteoarthritis. We also see age-related degeneration. And so any of us that are 35, 40 or over are certainly familiar with what this is and what this feels like in us. Like as we age, obviously our joints will start to deteriorate somewhat, which can be, again, related to some of the things that we talked about a second ago as far as overuse and how we use them. There's also an increase in something called cellular senescence as we age, which can contribute to the inflammation in joints. There's a lot of factors there that we know about as ourselves, but then we can also kind of translate that also to horses and why horses may have more issues as they get older. Another issue that we can see is systemic inflammation or autoimmune issues. I think we don't recognize these, I think, as much in horses as we do in people. It seems like this has become, something that's fairly well known in people as far as systemic inflammation. I think we probably under-recognize it in horses when we're thinking about what we're feeding those horses and what may be contributing environmentally to horses that may have joint problems or inflammation. So I think that's an area that we can certainly, not in this talk, but just I think in the industry in general, is really hone in more on how we can decrease systemic inflammation, mostly through dietary changes. So what's going on in this joint? So we've talked about the anatomy, so you have kind of a basic understanding of that. We talked about some of the things that can trigger this process, but what's actually going on in there once this process starts. And so this is a very simplified diagram. And so the DAMP, so DAMP, just stands for damage-associated molecular patterns. And then LGI is low-grade inflammation. And so this whole process here, we're looking at kind of this low-grade inflammation cycle that starts off and early on probably doesn't cause any pain, but then as it progresses, we start to notice the symptoms. So some of the problems sometimes with that is that there's already this cycle going on before we even are able to intervene. And so by the time we intervene, there's already permanent damage that we can't reverse. So the goal in some of these cases obviously would be to intervene sooner if we can. So if we think about what's going on here, if you look at the bottom, that's the chondrocytes. So chondrocytes are cells that are in cartilage. And so if those cells are damaged or they get signals that there's something wrong in that joint, they'll release different proteins and proteases in the joint. So different things that are associated with damage to the cartilage. And so what happens is these get released in the synovial fluid. They're mixing around that joint. And on the lining, so on the inside lining of the synovial membrane, again, that's the part that produces the fluid, you have macrophages and fibroblasts, among other things. But those are the main structures that are there. So those macrophages, which are a type of immune cell, they have little sensors that notice all these proteins and proteases that are circulating in there. And so they form a response to that. And part of that response is they start releasing cytokines. So cytokines are proteins that aren't good or bad, but they're little cell signalers in the body to turn on and off certain things. And so we have cytokines that are inflammatory and cytokines that are anti-inflammatory. But what happens oftentimes is these macrophages will start to release these inflammatory cytokines that then further damage the chondrocytes. So you can see how we get this cycle. So we get this cycle of cartilage damage, releasing proteins and proteases. The macrophages then say, oh, hey, we've got this damage. Let's release these cytokines to counteract it. But those cytokines start to damage the cartilage. And so, again, we get this cycle. And so when we think about how we want to treat joints, I tried to think about where I'm going to intervene in this cycle to be the most effective. So how do we choose what to use? And this is we as in veterinarians, but then also talking to our clients and making decisions on what we want to use. So I think number one is something has to be safe. And safe means we're going to cause no harm. Certainly, we want to feel good that when we use something that we're helping the horse. And if nothing else, even if it doesn't work, we certainly don't want to hurt that horse. And so when we think about safety, one thing is flares. So flares are typically just something that anything we put in a joint can cause an inflammatory reaction where the body just has this immune reaction to it. Typically, flares are short acting, usually about 3 days. But certainly we want to minimize those as much as possible. And so we want to have a product that isn't going to cause flares. We have to think about the metabolic status of a horse, especially if we're going to think about using corticosteroids. Because if we have a horse that has PPID or Cushing's, then using corticosteroids can cause that horse to have a lemonitic episode. And also horses that are metabolically challenged, that have equine metabolic syndrome, same scenario, using corticosteroids can founder those horses. So we have to be really careful there. In the same way, if we're treating pregnant horses, we need to be careful about corticosteroids. And then again, safety comes into other things like not wanting joint infections, keeping things sterile, all that kind of plays into all our products as well. Number two, like once we know if something's safe, number two, we want it to be effective. And what is effective? Well, we need to think about if something helps, how long does it help? So looking at the duration of effect. We need to know how quickly it's going to start helping. And then also we need to know efficacy relative to severity. So there's a broad spectrum of joint damage that we can treat. And we'll use different products based on the severity. So that plays a big role. And then some of the factors secondary to those or tertiary, I guess, would be the cost of the product. So obviously, for some people, cost doesn't matter, but a lot of people it does. And so we have to factor that in. Also, client preference. So sometimes I'll get clients that come in and say, oh, I had this other horse injected with this product and it worked great. So that's what I'd like to use this time. Or I had PRP injected in my knee last week. I feel so much better. Let's do that in my horse this time. Things like that. And then also just ease of use. So this plays into how much processing and how much time is involved in processing to treat a joint. So I rarely use stem cells for multiple reasons, but one of them is that if you're deriving stem cells from the horse you're treating, you have to draw bone marrow out of their sternum. You have to send it off to a lab. You wait till they get it back. It's really expensive, and so for that reason, I don't use many stem cells anymore, and not just for that reason. But that's one of the main reasons. So what are our goals? So some of these will play into the list we just looked at, but we need to look at time frame. So time frame includes time frame to when that horse is going to compete. So if I have a horse that needs to be at a show in 3 days and it's sore today, then I may use a different product than I would if that horse has a show in 6 weeks and we just want to make sure that horse is good in 6 weeks. Also, we have to think about withdrawal times, less so with like our orthobiologics that we're going to talk about because most of those aren't detectable. But certainly if we're using corticosteroids or things like that, then we have to consider withdrawal time so these horses don't get a positive test at the show. And then we need to think about how long it takes effect and how long it lasts. So does this product have a disease modifying effect? And so by that, I mean, like when we're looking at that chart before, can it slow down or stop some of this cycle so that we get a longer joint life from that joint, like usable joint life from that joint? And again, we have to think about onset, how quickly it works. And then again, all that is relative to the severity of what we were treating. All right, so just do a quick overview, and this isn't an exhaustive list by any means, and there are a few other categories of things that we'll sometimes use in joints, but I've picked the big three categories that we use most commonly. So first, we have corticosteroids. Those have been used for forever. As long as we've been treating horse joints, we've been putting steroids in them. So our long-acting steroids that are most commonly used in joints are triamcinolone, betamethasone, and methylprednisolone. So typically, methylprednisolone is going to be the longest acting, but it's also pretty damaging to cartilage. Triamcinolone and betamethasone are long acting, usually not quite as much as methylprednisolone, but they're a little safer on joints. But again, then triamcinolone especially is prone to causing potentially cause founder in horses or laminitis in horses that have metabolic issues or Cushing's. Then we think about our viscose supplementation category. And so first there's hyaluronic acid. So you should be familiar with hyaluronic acid. That's what Legend is. There's multiple products out there that are given orally, that are given IV, and they're given also in the joint. These have been around for a long time. They've been used quite a bit in the equine industry. I use less and less of these all the time, just because mostly on the human side, listening to human doctors and looking at a lot of the human research, they mostly think it's anecdotal at this point. So I use less and less of it. I do think IV, it works well, things like that. I use less and less of it in joints. Now we have two others that are out there. There's two main products that are viscose supplementation, and both of these are polyacrylamide hydrogels. So there's a 2.5% hydrogel, which is Arthromed, and there's a 4% hydrogel, which is Noltrex, and they're actually quite different products. They work very differently. They have, I think, very different use cases most of the time, and they both have a place. Certain places where they're really effective, but they're actually quite different. Then we have orthobiologics. So orthobiologics are this broad category of biologic regenerative therapies. All right, so let's break down our orthobiologics a little bit more. We have autologous, which means it comes from the same animal. So with this, you're looking at PRP, so platelet-rich plasma. A common type of PRP is Prostride, which is actually like kind of concentrated PRP that's upregulates some of the products in it. We have IRAP, which has been around for quite a while. We have A2M, alpha-2 macroglobulin, or alpha-2 EQ is the brand name of the product. We have stem cells, and we have bone marrow aspirate concentrate, which is bone marrow just taken from the sternum typically and then concentrated and injected back in the horse. Then we have our allogenic products. And so these are products that come from a donor. And so one category is birth-derived products. Typically, most of these products involve using amniotic fluid and with other components of the amniotic sac, like the amnion and things like that. There's different formulations of it, but the one we're talking about here today is Strydaflex. So Strydaflex is a birth-derived allogenic product. And then there are stem cells, allogenic stem cells out there as well that you can use from donors. I've used some of those in the past. I've had more issues with flares on those than I have with a lot of products, but that is an option out there. All right, so how can we interview? So we talked about this cycle here, talked about the products and how we can slow down or stop this process. We know that one way or the main way to intervene, I think the best way to intervene is to start to interrupt some of this cellular communication, or at least steer it in the direction we want it to go. A lot of the new research out there is looking at macrophages and the role that they play in osteoarthritis. There are two types of macrophages termed M1 and M2. M1 macrophages are typically considered more of the anti-inflammatory macrophage. And M1 is typically the inflammatory macrophage, and M2 is the anti-inflammatory macrophage. So a lot of our products, we look at how they affect macrophages, and we want them to shift to be able to help that joint shift from M1 to M2 type macrophages, which then can help decrease the inflammation in the joint. We also have these cytokines and chemokines that are released in the joint, typically from the macrophages and from other cells around the joint or in the joint. again, these can be anti-inflammatory and inflammatory. So one way we can interfere here is we can introduce anti-inflammatory cytokines into the joint, or we can introduce products that bind up inflammatory cytokines into the joint. Here's a little diagram just kind of looking at some of our products and where they can intervene. So if we start here at the chondrocyte level, there is one of the polyacrylamide products can actually form some coating in that area, which I didn't put that on here. But then we look at our inflammatory products that are released by the cartilage, and we think about our proteases, and that's where the A2M product comes in, or the A2EQ product comes in. So it helps to bind up those proteases that then they don't make their way to the macrophages. And then they can bind up proteases on the other side of our diagram as well. Then at the macrophage level, we have arthrimid, which actually integrates into the synovium, and we know it does influence our macrophage population in the joint, that M1 to M2 shift. We have bone marrow aspirate concentrate, which can act at this level. Bone marrow aspirate concentrate also has some A2M in it as well. We have exosomes, and I'll show you a little study here in a second, but we know that exosomes also help with that M1 to M2 shift. And Strydaflex is has a large number of exosomes contained within it. Then we look at the cytokines. Again, Strydaflex, we know that Strydaflex has anti-inflammatory cytokines in the product. It also has IRAP, which helps bind up one of the inflammatory cytokines. Again, the product IRAP is there too as well, which helps bind up an inflammatory cytokine. Then we have PRP, and PRP has a lot of growth factors. It has some anti-inflammatory cytokines as well. And so all these products, I think, are good products. They all have their place in joint health. I think sometimes probably a combination of one or two of these, like combining arthrimid and Strydaflex, maybe not at the same time, but a few weeks apart, maybe optimal in some cases. I'm doing more and more of that now. Once I think about the process going on, I think probably targeting multiple areas of this is ideal. So what's an exosome? So this may be a new term to y'all, so I'm just going to do a quick little description of what they are. So it's a type of extracellular vesicle. So basically that means a little vesicle that's outside of the cell. They get formed inside the cell, and then the cell will kind of batch them up and then spit them out. And what they contain are proteins, peptides, lipids. They have nucleic acids, so RNA. There's over 6 types of RNA contained in exosomes. There's other metabolites as well. And so they get released into the cytoplasm, and then they have a cell that they're targeted to go to, that they're enveloped into that cell, and then they have a specific role there in that cell to play. All right, so we can see here on the left, we have a little diagram of a cell that's spitting out exosomes. We have another cell with receptors that's taking them in. And so those exosomes have a specific site. And so when they get to that site, then that cell recognizes them and pulls them in. And so, like I said, we have that RNA, which is genetic material that goes in there, and then it's transcripted, and it tells that cell, okay, produce this or don't quit producing that. So I kind of think of them, they're like a carrier pigeon, the message in one. They're one of the main ways that cells talk to each other. I mentioned before about exosomes and with that M1, M2 shift of polarization of macrophages. So this is just a study here. The study was actually done with umbilical cord stem cells, but it did show that they ameliorated the progression of arthritis and exerted protection of the cartilage in osteoarthritis in a rat model by promoting that M2 macrophage polarization shift that we mentioned earlier. So this study did show that exosomes do promote that shift and help have a protective effect in the joint. So what's in Strydaflex? So it does contain exosomes. It also has growth factors and has cytokines. Now, cytokines, as I mentioned before, can be inflammatory and anti-inflammatory. It has multiple cytokines in it that are anti-inflammatory. Some that also help bind up some of the inflammatory cytokines. And then they did a spot capture analysis, which you can see there on the left, which looks kind of like a starry sky, but basically counting the number of molecules in there that could be exosomes, looking specifically in a certain size range. And per dose, what they found was that there are 3.5 billion of those those right-sized particles to be exosomes and Strydaflex. No, we don't. We're still learning a lot about exosomes. There's a lot we don't know. We don't know what the proper dose is. But I mean, 3.5 billion sounds like a lot, but obviously that hasn't been pinpointed. But we do know Strydaflex has a lot of exosomes in them, and we're still kind of learning. Okay, what's the right dose to put in the joint? So what I like about Strydaflex, well, one is it's safe. So I've used quite a bit of it, put it in quite a few joints now. I've never had a flare from it. Never had any kind of negative issues with it after injecting it. I like the consistency of it, and consistency, by that I mean I know what I'm getting. And so I've got a vial that contains Strydaflex in it, and I know it's got that 3.5 billion of exosomes in it. I know the amount of certain cytokines in it. I've seen the printouts when the Hilltop Bio does a great job of analyzing and quality control. So that gives me confidence that the dose I'm injecting is I know what that is. Some of our other products, like if you think about PRP, which I still do use a lot of PRP, but with the kits and depending on how you process it, you don't really know what you're injecting sometimes, and that's can differ from horse to horse unless you're testing each horse. And so with this product, I know exactly what I'm putting in there, and also it's high quality, it's sterile. All those things give me confidence. It's really easy to use. So it comes in a vial. It's stable at room temperature. All I have to do is inject some saline into it. It dissolves the lyophilized product inside. Then I just draw that back out, and it's ready to inject. Super easy, super quick to use. And also, I'm seeing results as well with it. The horses I'm treating, I'm seeing those horses improve. So that also gives me confidence in the product. All right. And so what cases do I think about using it in? Well, it's really my first line of defense if I have a horse with a joint injury. So we talked about joint injuries before. So that could be a horse that damages the cartilage in the joint. That could be a horse that damages the bone right under the cartilage. It can be a horse with soft tissue injuries around the cartilage, like a collateral ligament, or just a synovitis, inflammation in the joint. Or I also use it oftentimes for post-surgical horses. I'm not a surgeon, but our surgeon in our practice does quite a bit of joint surgeries. And so typically about 2 weeks after that surgery, about the time we're taking the sutures out, we'll go back in and inject Strydaflex in that joint, try to help the healing process move along inside that joint after surgery. Also, if I've got soft tissue damage or cartilage damage in or near a joint, then I'm often using it for that. So we have a CT, and so we're often doing contrast CTs on joints, which we can see cartilage damage, we can see soft tissue damage. So if I find one of those things, like on the CTs I'm doing, then oftentimes I'm coming back and injecting Strydaflex in there, or combining Strydaflex with something else. Like I said, usually if I combine it with something, what I'll do is I'll inject Arfamid most commonly, usually about 2 or 3 weeks after I inject my Strydaflex. Trying to hit that diagram we looked at different locations to make sure we get the best results we can. And then just looking at the long-term view on joint health and management of osteoarthritis. So I wish all my clients had a long-term view of joint health. Some don't. They just want to get through next week. But those clients that want to have this horse around for the next 10 years, then I think it's a great product, because looking at that exosome study earlier, we know that it has effects that has a chondroprotective effect, just meaning it protects the cartilage and also slowed down the progression in those joints. So I think for that reason, it's a great product, and one that if we're looking ahead, I think it's one certainly to have in our arsenal. And that's it. Let's see. We go through some questions here. So which joints have I injected with Strydaflex so far? Let's see, stifles, hocks, fetlocks, put it in some knees, coffin joints. I think those are the main ones. I don't think I've injected a shoulder with it at this point, or an elbow, but those are certainly places that we don't inject very often. But those are most common joints that I inject are fetlocks, coffins, hocks, and stifles, and certainly I've put it on in all those multiple times. We have a question. My horse is knuckling over in the front pasterns. Began as she was 2, now 6. So I guess I don't see the question there. Can you explain more about why you're moving away from Legend, Adequine, and Pensand? Well, I didn't say I was moving away from those. I certainly still use a lot of Adequine. I think it's a great product. I recommend it in the horses. I think it's a great, to use along with your joint therapy. So I think there's certainly a place for Adequine, and I sell a lot of Adequine just because I do believe in it. I just haven't used as much Pensand personally. It's supposed to be similar to Adequine. I just haven't got into using it much. So I don't use it as much just because Adequine I'm so comfortable with. And I still think Legend's a good product as well. I'm just not putting them in joints as much. I still think they're good systemically, but I think there's better products now as far as injecting something straight into a joint. Is this a great option for metabolic horses? Yes. So basically all our orthobiologics and also the visco supplementation products are generally safe for our metabolic horses. So if I've got a horse with Cushing's, then I'm going to jump to one of those. I'm not even going to think about putting corticosteroids in those horses. So in those cases, I think that's definitely the way to go, is to use Strydaflex or PRP or one of those type products. How does this compare to ProStride? So it's different just in the sense that, so ProStride, you're taking a horse's blood, you're spinning it down, you're concentrating it, and then you're getting back a product that's got PRP in it, it's got some IRAP in it, it's got a little bit of A2M in it, and so it's a similar product. And there are some similar proteins and cytokines and some of the things that are inside of it. But with the ProStride, you don't have the exosomes, which would be one difference. Can you use the steroid to put out the fire post-use, or is this for a barrel use of this for, say, a barrel futurity horse? So there are cases where I will use a steroid if a horse is super sore, super inflamed. We need to get that inflammation down, as fast as we can. Or that horse, like I said before, that if that horse needs to compete in 3 days, then a lot of times our orthobiologic products just aren't going to work fast enough. And so sometimes we have to use a corticosteroid, but oftentimes what I will do is use that steroid to kind of put out the fire, like you said. Then I'll come back a few weeks later and inject Strydaflex or inject one of these other products a couple of weeks after we've gotten that inflammation down, because I still want that long-term benefits from our regenerative therapies or our visco supplementation products. How long does Strydaflex last? So we'll see results anywhere from 6 months to a year, typically. I've been using it for about a year, so it hasn't been around a long time, but I have been using it that long. And so I haven't had any horses yet that I think I've had to re-inject. And so I've been using it for about a year now. Okay, you have an 18-year-old quarter horse, equine metabolic syndrome, and showing stiffness in his rear hocks, always resting his foot, going to vet in a week for checkup. How long does Strydaflex typically last? So again, 6 months to a year. Like if you're getting like in those cases, if you've got a hock that's severely fusing, I'm probably not going to jump for Strydaflex. Or most of those, or PRP or anything like that. And typically in those cases, we're looking at sometimes like depot or shockwave therapy or other things. So it kind of depends on the pathology in a hock. Sometimes hocks are fused or fusing, and that will dictate whether you want to use an orthobiologic or Strydaflex versus something else. So I would obviously consult your veterinarian on that one. Does it come with dosing instructions like Noltrek? So it comes in a single vial, and typically you reconstitute that vial with 2 cc's of saline. Now I have, if I wanted to inject it in more than one joint, or if I want a larger volume, like a stifle is a big joint. And so if I want to inject a stifle with Strydaflex, which I do, sometimes I'll put like 5 cc's in it just to make it give it more volume if I'm putting it in a big joint. But on average, it would be 2 cc's. It is a good option for injections in younger horses. Again, just because of that reason we talked about, as far as it helps protect the joint, you're going to get some cartilage protection. You're going to get some decreasing in that cycle that leads to ongoing arthritic problems. So from a standpoint of young horses, I do think it's a good product from a long-term perspective. How long do you wait after injecting polyacrylamide before injecting Strydaflex? So typically, I'm going to wait at least 2 weeks in between injections on those products. It takes the polyacrylamide 2 weeks to start to integrate into the synovium with our speaking about Arfamid. So Arfamid integrates in the synovium, Noltrex doesn't. So they're different products. But with the polyacrylamide like Arfamid, I'll try to at least do 2 weeks spacing in between the injection and Strydaflex or something else I'm injecting in the joint. All right, did we get all the questions covered? Can you expand on inflammation in the joint and the role of grains? Yeah, it's kind of outside the scope of this discussion. I do think certain grains can be inflammatory to certain horses. I certainly have had horses that were having issues that we often will just take grains out of their diet completely and put them on a forage-based diet, and those horses get better. I think like people, it's horse specific. So some horses can tolerate, a certain grain or a certain product fine, and the horse can't. We're finding flax oil affects a lot of horses and causes systemic inflammation. And so that's a very horse specific thing, but I do think that certainly looking at that is important to do if your horse is having a lot of inflammatory issues. What's my opinion about using some corticosteroids in the joint and after this, the Strydaflex? Again, I think you could do that in the right situation. And I have done that before where I needed to get a horse ready for an event in a couple of days. And then we came back a few weeks later and injected Strydaflex. And I think that's an okay way to do that. Again, it's all situational depending on your time frames for competition and things like that. Have you used it in horses with simple non-weight bearing OCDs and stifles? I don't think I have used it in a stifle with osteochondrosis. I think I may have used it in a horse that had a bone cyst prior. That might be the only case of it. I haven't used it a lot for treating OCD and stifles, more osteoarthritis and post surgery and injury type things. Okay, what's the typical post-injection protocol? So typically what I do, I usually just stall rest horses for about 24 hours after an injection. After that, you can tack walk them or hand walk them for 3 days, or have them in a small paddock turnout. Depending on how lame the horse is or what we're treating, I may have those horses go back to light riding 3 days later, or sometimes I'll wait a week. That all depends on the horse, how sore the horse is, a lot of factors that go into exactly when I have those horses go back into riding. But typically somewhere between 3 to 7 days. That's all case dependent. What's my opinion about polyglycan? The studies that were done at Colorado State University on polyglycan weren't great as far as using it in joint or using it systemically. I use less and less of it now than I used to. I mean, I did used to use it quite a bit, but based on some of the research, I use it less now than I used to. I haven't completely quit using it, but I do have clients that like it and think it works. But the studies on it haven't been great. All right. Any more questions here that we haven't addressed? Here's one. I have a 3-year-old who has a cutting training last year. Now the Ferris suspects navicular. Front shoes are helping. I guess there wasn't really a question there. I have not used Strydaflex for navicular. I I have had some. I probably should. I've had some success using PRP in navicular bursts and coffin joints. So I probably need to start trying Strydaflex in some cases to see if it would help in those cases. So I think there could be a case use for it, but I have not tried it yet. All right. We'll look through these questions. Have we seen anything else here that we haven't addressed?
I think that's all the questions that we had for.
Okay.
But thank you so much, Dr. Whitaker. It was very interesting. And if you're a veterinarian, you can reach out to us to set up an account with Hilltop. If you're a horse owner, you can reach out to us for any questions. Visit our website at hilltopbio.com or send us a note at info@hilltopbio.com, and be on the lookout for more webinars in conjunction with Horse Network for this year. And have a great evening.
Thank you all for attending.
I'm Will Coleman.
My name's Liz Halliday.
My name's Megan Kefferly.